We'll start with the first presentation by Dr. Chinmoy.
I'm going to present a case of LMC intervention. Mr. GK, a 45-year-old male, he came to emergency department at 11 p.m. with complaint of chest pain from last 1 month, which has aggravated over last 1 day and continuing throughout the day. Along with a history of swelling of both lower limbs from 5 days, with a background history of 1 episode of loss of consciousness, which was preceded by chest pain. He was a diabetic and a smoker without any family history of coronary artery disease. On examination, vitals were stable. Only positive finding there was edema, and chest there was bilateral basal crepes. Systemic examination were non-contributory. In the ECG, we got ST segment depression, widespread T-wave inversion, 2, 3 AVA, V4, V5, V6, and ST elevation in AVR. There were dynamic changes. As we have observed the patient, there were dynamic changes in ECG. Troponin was negative. Blood picture showed normal hemoglobin. The abnormalities were triglyceride, cholesterol, LDL were raised. Other parameters are normal. The blood sugar was raised. HbA1c was 6.9. Echocardiography, there was EF was 57%. There was no abdomen. Patient was put on aspirin, clopidogrel, beta blocker, statin, ACE inhibitor, and LMWH, and we planned an angiography. Just while he was waiting in the cath lab, he had a cardiac arrest. He had asystole. We resuscitated him, and a coronary angiogram was done. It was showing ostial LMCA around 90% lesion, as you can see in various views. Since he had an asystole, we decided to put him on temporary backup. Besides this, on the left system, there was no other anomalies or stenosis as such. Next slide. RCA non-dominant, normal RCA. Next slide. We did a Lima shot. Next slide. So we decided to go for LMCA stenting in this patient. Our plan was to put a 4/7 stent in the proximal, ostial proximal LMCA. We couldn't arrange on the day one, the day when the angio was done. So we placed the patient for next day.
Speak into the mic, please.
We placed the patient for the next day. So first shot we took, and the sinus shot was taken. We can see our LMCA is going down. A stream of this dye can be seen there. Next slide. As soon as the first shot was taken, the patient went into a cardiac standstill. We immediately started CPR. You can see there the no coronaries could be seen here. Only a sinus, there's some coloring of the sinus only. Nothing was visible. Next slide. Same thing happened. Another shot was taken. Nothing is visible. Next slide. So took out the guide cath. We took one GL 3.56 French diagnostic catheter and tried to engage the LMCA if possible. Luckily for us, we could engage it and we could find a path through which we can go. Next slide. We took a BMW guide wire. Over that, we took on 1.5 by 10 mm balloon. We did dotting several times. Next slide. Next slide. We take out the whole assembly. We took another EBU catheter and engage the LMCA. Then we take the 4/7 stent and we inflate exactly in the ostium and proximal part. Next slide. You can see there, it is deployed there, a flow has come. Next slide. Next slide. Throughout the procedure, CPR was going on. We are giving chest compression, intubation was done. Chest compression was never stopped. We continued it throughout the procedure. Next slide. In this slide, we are trying to show the deployment. At the proximal part, there was some under deployment. So we decided to put a NC balloon, 4/9 mm, and to inflate it further. Next slide. You can see there CPR was going on. At the same time, we were inflating the balloon. Next slide. After that, we took a check shot. Here you can say the heart started to contract. Next slide. It's contracting vigorously. And next, please. Yeah, this is the final shot we had. Luckily for us, the patient, we could survive, save the patient. Patient extubated within the next half an hour, and he's fine now. Next slide. With that, I'd like to conclude, sir.
What was the ejection fraction at discharge?
Sir, 57%, sir. 57%.
Why have you not put intra-aortic balloon pump on day 1?
IABP.
Sir, we don't have any IABP in our institute, sir.
Okay.
In cardiology department, we don't have any.
Was it a bare metal stent or a drug-eluting stent?
Yes, sir. That's the drug-eluting stent was put, sir.
What was the drug-eluting stent you used?
Sir?
What was the drug-eluting you used?
Sir, I can't disclose, sir.
You cannot disclose. Okay, that's a nice presentation. Highlights a lot of things, including the limitations that we face in the government hospitals. And well, I guess in the end, the patient survived, and you guys did your very best. It's one thing that strikes me is a 55-year-old man with just, I said, one thing that surprised me was a 55-year-old man with just an ostial left main lesion and absolutely pristine entire arterial tree.
Yes.
Would you think of any other cause other than atherosclerosis? Or considering his age, you would only think of atherosclerosis as the possible reason?
We reviewed the case, sir. We couldn't find any other possible cause in this, like any causes of hyperhomocystinemia or other possible causes.
Was the VDRL done?
Sir?
VDRL. Syphilis was rolled out. Syphilis. VDRL.
Oh, we didn't do that, sir. We didn't.
And I don't know, I found it a bit odd. A patient who comes to an emergency, and I don't know why Lima was injected. If you do not have any idea of sending for an emergency surgery.
I'm not getting your question, sir.
Lima was injected and all.
Lima?
Why was Lima injected?
Yeah.
Can
The reason was that, sir, whether to go for CABG or PCI in this case. Basically, we had a doubt in our mind. The patient party, when we consulted with them, we told them, given them the options, they were not ready for bypass. That's why we opt for PCI in this case.
But normally, this type of situation, even the angioplasty and stenting is a good option now. After the syntax, you had say ostial left main, discrete, other the distal vessels are very clean, LV function is good. And naturally, this is one of the good case for left main stenting, PCI as well.
Dr. Murthy?
The only thing is that one has to be prepared, like the patient came with unstable angina, without balloon pump, doing this procedure, and not keeping patient on balloon pump, in fact, would probably
it's quite risky, sir. It was very risky.
I think there are a couple of things here. First thing is, patient had an arrest before.
Yeah.
So this patient, when he is taken, he was showing a tight left main. He should not take so many shots first.
Yeah.
The second is, since it's a dominant system, you need not go for RC injection or Lima injection. After taking 1 or 2 shots, they should straight away put in a stent, which should have avoided all this nonsense.
All these.
Anyway, there is always learning points. We encourage them. Thank you very much.
Thank you.